Philippe is recording the call. Am I on?
Yeah, I'm recording. You watch the Skype message saying I'm recording, and then after the call was ended, Skype will post it for you and me only.
Okay. And do you see me?
No, I'm not seeing you. In the main page of Skype, there's 3 buttons below.
Yeah.
First from the left is microphone on and off.
Yeah.
And the middle one is the camera.
Yeah.
And
it says it's on. Let's try this.
Okay.
Blur my background. Camera. Web plugin virtual camera. Oh, it's looking for a different camera. There I am. You got me? Do you see me?
Not yet.
I see myself. Let's try that.
Oh, okay. Now I see you. Are you see me?
Yeah, I can see you.
Yeah.
Let me close the door. Hang on a second.
Okay. No problem.
Okay.
Okay. Thank you very much for having this conversation with me. I'm very proud and happy for doing this. I'm reading your papers on screening for quite some time now. And let me show you what I have here. I don't have your books in print version. I have many of yours in Kindle, so you don't have the same effect of showing here. So, but I have this one. Can you see it?
Yes.
Yeah. It's Raphael Gray screening textbook.
Yes.
Yeah. And then this is the magazine I sent to you. It's with my cancer screening article.
Very good. Yeah,
very good.
And it's in English.
It's in English. Yeah. It's a American magazine for science and reason, skepticism, popularization.
But you're Brazilian.
I'm Brazilian. Yeah, I'm Brazilian. And my history, in short, is that I opened a blog for science popularization. For Brazilian people, actually, because I thought back in 2012 that many people are doing great science popularization in the United States, but that popularization happens in your country, reach me in Brazil with more strength than in Brazil, so more bold. So I think I could try to help with that. Yeah. But I didn't get so far many popularization here. We don't have many magazines for science popularization here. For instance, Scientific American here, I think it's just a version that they select the best test in English and translate it for here. I have emailed them for publication, never received so. So I tried to publish my contacts back in US, and I got much more acceptance, much more acceptance.
Well, that's great. Congratulations.
Thank you.
And where are you?
I'm in Brazil, Rio de Janeiro.
You're in Rio de Janeiro.
Yeah, Rio de Janeiro, yeah. And then I did a PhD in University State of Rio de Janeiro in medical science, even though I'm not a MD, I'm not a medical doctor.
Yeah. But you're dealing with science in general, not just medicine.
Yeah, in science writing, yes. I have interviewed physicists. Lawrence Krauss is a bit famous. And in the medicine, I have interviewed Paul Offit. You probably have heard about him. He's a pediatrician, rotavirus inventor, vaccine inventor. I have interviewed Carl Hart, which is he's a neuropsychopharmacologist. I did an interview with them. It was a cover story for Skeptic magazine.
Yeah.
No, so I'm doing this a couple of years now.
Oh, so, well, that's great. And you're putting together a freelance article that you'll then pitch to a couple of places?
What? I'm sorry?
You're putting together a freelanced article that you will pitch to a variety of places?
Yeah. I have everything that I have published in my blogs. Not 100%. I think that's what this question is about, right?
No. The question is, why are you calling me? Are you have you been commissioned to do an article, or are you putting together an article yourself that you're going to pitch?
No. I'm going to try to put an article myself. I have done this kind of things. I do all the stuff for me together, prepare the transcript article, and then I submit for interview. I submit for publication, those magazines for popularization. Hopefully, I can get both ways, published in the US and Brazil also, but in the last part has been difficult for the last year. So,
I do know you're not the first Brazilian reporter to interview me. And I think my second book actually came out in Portuguese.
I didn't know about that. That's one of the things I try to always check because what I said about science popularization, even books over here don't have many translations, versions for Brazilian readers. Right. So what I like to do is talking to people like you that researcher and then also writing science to the general audience, so we can have the both ways integrated. But no, I don't know always I have English books translated, so
right.
It's a difficult. I have considered to translate books myself, but it would be a tremendous amount of work. Yeah,
tremendous amount.
Yeah. The interviews are already amount of work because I generate everything in English and then pass everything to Portuguese.
Right.
So almost everything that I publish in English is also found in my blog in Portuguese.
Well, that's great.
That's good.
Well, why don't you fire away or tell me how you want to do this?
Well, I have a couple of questions here about screening, and we're going to try to discuss them.
Okay.
Okay. So I like to begin with simple, because when I'm talking about screening about people, they have some sort of issues to understand that screening involves only asymptomatic people, and I'm afraid that some of them understands that we're talking about I don't know, should never do medical exams anymore, diagnostic medical procedures. In many cases, they are the same tests, right? Mammography diagnostic, mammography screening. So how can you make this message very clear?
Yeah, well, let me just step back and say that some people, one mammographer has suggested that I'm dangerous. I'm one of the worst things that's happened to American medicine. But I like to start by saying, I'm a conventionally trained physician, and I genuinely believe medical care can do a lot of good, particularly in selected settings. People who are acutely sick or injured. And making diagnoses timely in people who are sick and injured is like really important. So it's not like I'm against diagnostic technology or anything. Medical care can do a lot of good. What I worry about is when we expand out into the well population, and it's hard to make a well person better.
That's a very good argument.
That's really important. Yeah. But it isn't that hard to make them worse. And I think for a while now, we've really focused on those that we might be able to help, but we don't consider what happens to everybody else. So maybe we involve 1,000 people in a screening program for 10 years, and one person's helped. Well, that's good, but the question is, what happened to the other 999? And that's sort of where I've been in my career for the last 20 years.
And I think screening is a fascinating topic to research. I have studied and many of your papers and Wallerstein, Laura Esseron, many to write for personal interest and curiosity. And for example, you've mentioned often about the misleading screening statistics about survival, the 5-year survival.
Yes.
Yeah. So just to give a step back, what is the main problem with screening?
Yeah, that's a very good question. And the main problem is whenever we look for early forms of disease, we find more than we would otherwise. Whenever we look hard for early forms of disease, we find that more people have them. And not all those people will go on to develop the disease. But we're not sure which is which, so we tend to treat all of them. And that means we're treating some people for whom the disease will never be a problem. And that's the overdiagnosed fraction. They can't be helped. They can't be helped because they were never going to have a problem, but they can be hurt.
Be harmed.
And that's the real issue. And then the second piece that you just mentioned before, so we look harder, we find more. The second piece is the typical patient now does better. And that's the really misleading feedback. That's the survival statistics among patients with the disease. They survive longer because you've now included more people. So that's really misleading. You look harder, you find more, and everybody appears to do better. So that's a real conundrum.
Yeah, that's the popularity paradox.
That's right. Yeah, the more overdiagnosis of screening test causes, the more popular it becomes. But even if that problem was taken away, our statistics in medicine, if they're case-based among patients, every measure will appear to do better because you're now including people with less, either they're overdiagnosed or less severe forms of the disease.
And even if you're talking about even the lead time, introduce lead time bias.
This is a lead time effect, and it's also an overdiagnosis effect. Yeah.
And focus you on.
Can I stop for just a second?
Okay, no problem.
Can I share my screen with you?
Yeah, I think you can. I'm not sure how, but I think you can.
Yeah, share screen. Okay, so start sharing. Let me just show you one. So I'm going to put you down here. Can you see my screen?
I am seeing a desktop right now. Yeah.
Yeah. Okay. Let me just open a. I don't know. Do you ever use figures?
Yeah, I like figures.
Oh. I just got to give you this quote now that I'm here. Can you see
I know Carpenters. I know who is a.
Yeah.
Yeah.
Can you see it? Enormous negative impact on the practice of medicine. But what I was really looking for is going to be in the other one. This is the slide that I think is important to this. And in the past, doctors treated a population. Each one of those dots is a member of the population. Can you see this?
Yes, I'm seeing.
And we waited for problems to develop, and then we made diagnoses and treatment in that fraction. And the early diagnosis ideal was very simple. Take that same population and advance in time the point of diagnosis, with the assumption that what we found early, the natural history was that these are people destined to develop problems. But the reality's been quite different. Whenever we look early, we find more patients. And that means the natural history must be more complex. Hopefully we found those destined to develop problems, but sometimes you don't, because the people destined to develop problems do so quickly. But at the very least, now we've got a whole new fraction, those not destined to develop problems. And that is the overdiagnosed and needlessly treated fraction. And I don't know if that picture helps, but I would be very happy for you to use it if you wanted to.
Yeah, it will help. Certainly does. Tomorrow, I'm going to do a lecture for my friends that I work with about screening. They are not medical doctors. They are not for medicine. They are usually computers, programmers, and they are interested in statistics and medicine. So I might include this figure. It's a very great figure. Yeah.
Okay.
I have
conceptual figure. Yeah.
Yeah, it's very great. So we haven't yet focused on cancer screening, but I'm going to anticipate on a question. There is a general screening that is well justified and effective.
Oh, was that a question?
Yeah, is that a question? Yeah, if there is a screening program or a test
I'm often asked this question. I think the thing that people
because when I introduced my lecture, I said that screening can be opportunistic. For example, tell me if I'm wrong. I never felt CVD symptoms, cardiovascular disease symptoms, but every time I go to the doctor, you want to those cholesterol levels and so forth. I never felt, I don't know, glycose problems, diabetes problems, and then they dose.
Yeah.
Is this some sort of screening, right?
Yeah, it is. It definitely is. And you know, the screening, if you will, that I think in general most adults should know is their blood pressure. You know, if there's any asymptomatic disease where we have made a big difference, it's been in blood pressure control, people with really high blood pressure. So I think that it's very simple test is something that people should do or should know when they should have checked. You know, having a doctor who knows something about your family history, which is sort of the in many ways the most important genetic test there is, you know, what really has happened in your family, tells people a lot, tells their doctor a lot. And then knowing something about your lifestyle is really important. And you could argue that screening too, but you know, what kind of things you do, that may be very relevant to your health. I'm really focused on when we really look hard for an abnormality. And this has been a huge growth area in medicine because it's such a powerful idea to look for disease early, and there's such powerful economic forces at work because these are big markets. If you can argue that everybody should do something, that's a huge market.
Let me jump on that last part of your answer, because you said many people asking me in the end what's the incentives if the evidence, for example, cancer screening is not very forward, not very there as effective programs. What is the force that drives those programs?
Two things: true belief, you know. Bad disease, you know, cancer can be a really bad disease. There is absolutely no denying that. Bad disease, early detection must help. Must help. It's a solution to every bad disease. So that's a true belief. It's a true belief, and it's not a particularly informed belief because you don't know about the side effects. But true belief is a big part of it. Money's another big part of it. It's a great way to recruit new patients. It's good for pharma, it's good for test manufacturers, and increasingly it's good for our hospitals. It's a great way for them to bring in new patients.
Mm-hmm. But we can compare, I think, not sure if I'm wrong, but I think patients are more willing to do screening in advance for early detection than taking some sort of pill.
Yes.
And so I think people were afraid of some sort of chemistry or pharmacological situation, but we're not very too afraid of technologic medical exams or for some sort of thing that involves technology. I think that's a part of a culture inside of the patients, and also an order for the doctors, because doctors, I think there's a cultural shift from doctors, like your slide you present to me. Back then, we wait disease to happen, and there is a problem, and then now we're looking to early detection, but is my friend pathologist there is telling me there is a cancer, and he's a very renowned pathologist, he's got to be a cancer to treat. Doctors have been treating cancer in that way for years.
Right. There's definitely been a big shift into what I call anticipatory medicine, trying to anticipate what's going to happen in the future. There's a love of technology, and we've, I think, taught patients to believe that, you know, there's no harm from a test. They understand that medications can have harms, but they can't really imagine how, you know, a test could have harms. You know, you say, oh, it's always good to know, but they don't recognize the cascade of events that a test can trigger. So even a perfectly safe test, you know, can trigger a series of interventions that ultimately hurt people.
So focus on cancer screening.
Sure.
What have we learned? It was the heterogeneity of cancer progression. How is that impacted screening?
So let me just, when you use the word prevention, let me.
No prevention, please. I know that in many cases, PSA does not prevent prostate cancer, not even mammography screening.
Yeah, I just want to be clear that when we use the word prevention, it really holds down two very different aspects. One is health promotion, and those are behavioral issues.
Do not smoke.
Don't smoke, eat real food, move regularly, find meaningful relationships. All those things are really important. They're not very sexy, they're not high tech, but they're actually really important to your health. But when the prevention movement got medicalized, it became a technological imperative for looking for early forms of disease, which was really very different. So, I think it's important to keep those two things separate. That when the idea of prevention got medicalized, we got kind of drawn away from the health promotion aspect, and we started focusing on the early detection aspect. Now, your question was about cancer. And I think it was, what have we learned from our early detection efforts in cancer?
And in the progression of cancer.
Yeah. So what we've learned is that cancers are a whole bunch more heterogeneous than we originally thought. That they have variable growth rates and that abnormalities that meet the pathologic definition of cancer could have very different natural histories. And this has been described as the barnyard pen of cancers. And there are three animals in the barnyard: the birds, the rabbits, and the turtles. And the goal of early detection is to fence them in, to catch them early. But you can imagine the problem. You can't fence in the bird. The bird's already flown away, and these represent the most aggressive cancers, the cancers that are growing super fast. Mm-hmm. And they've already spread by the time they're detectable. They're microscopic metastases already. And screening doesn't help with these cancers. The real question is, can you treat them? And sometimes we can, but they're the worst type. The rabbits are hopping around. You can catch them if you build enough fences. And these are the cancers that can be detected early, that will bother patients, and where screening may help. For screening to help, you also have to have treatment be more effective early than it is late. And sometimes that's not true. As in most breast cancers, a larger, a 2-centimeter tumor can be treated as well as a 1-centimeter tumor. And then there are the turtles. And you don't need any fences because they're not going anywhere anyway. And these are things that meet the pathologic definition of cancer, but are either not growing or growing so slowly that they'll never cause problems till the patient dies of something else, or they're in fact regressing. And in fact, we're now beginning to get evidence that some cancers start and then they go away in some relationship with the immunologic. The unfortunate reality is that screening's really good at finding turtles. And doctors aren't able to distinguish turtles from rabbits, so we end up treating everybody, creating the major harm of early detection.
So, but the main harm of early detection, it is overdiagnosis or the cascade of overdiagnosed patient?
Well, I'd say there's two, maybe three harms. The one I've been focused on the most is overdiagnosis, and that is someone's told they have cancer, but that cancer is never destined to bother them, but they're treated for cancer and they suffer from the side effects and of the interventions for the cancer. That happens to relatively few individuals. Yeah. More people have the cancer scare. The test, first test is the false positive, the alarms, and so forth. And that's not as big a harm, but it happens to more people. And then the third category is, in general, as a way to promote these problems, promote this screening, we get everybody more worried about the future. We have to in fact, part of the promotional effort in a screening program is to get people to worry about a disease they might not be worried about otherwise. I think that has a compounding effect on the population. I worry that we're just getting everybody too worried about their health. Yeah. And ironically, part of health is not being too worried about it and not being too anxious about it. And I worry sometimes medical care is injecting a little bit of dis-ease into the population and affecting people's resilience. And a sense of resilience, I think, is a very important part of health.
Let's talk about specific cancer screening now. I think we can say that there's 2 cancer screenings that are being considered somehow successful. But even though, as you've mentioned, there is issues with them, there is cervical cancer screening and colorectal cancer screening.
Yeah,
I think many people that have criticized the screening have said that those cancer screening programs are of value. Yeah. I know that, for example, Angela Haffel has made many publications disclosing the problems that cancer screening can have.
Yeah.
But for instance, I don't think many people know that even cancer screening could be problematic. We are not talking about overdiagnosis of cervical cancer, it's precancerous lesions, but we can overtreat people in the same sense, right?
Absolutely. So let's. So I agree. In general, people would put colorectal cancer and cervical cancer screening over to the side of more benefit than harm. And that's largely because the problem of cancer overdiagnosis is not evident in those two. That doesn't mean there's not overdiagnosis. I think overdiagnosis takes place at a prior step. Yeah. It's cervical dysplasia or, dysplastic polyps. And you're right. We can get people, stuck in loops of needing a colonoscopy every 3 years and having multiple polyps removed. And by the way, there are complications from colonoscopies. There are complications from polypectomies. In the case of the cervix, we get women who are having cryotherapy, freezing of the cervix, or they may be having excisions, not for cancer, but for those prior lesions. So that overdiagnosis can occur at a step before cancer. I think in general, cancer screening has a mixture of effects. I think most screening tests, including PSA, mammography, does help a few people. But it also hurts others. And that's the fundamental conundrum, which is, that I think we ought to be clear about. And I think the reason it's important to be clear about it is first to recognize this isn't a public health imperative. This is a choice. And by the way, it can distract people from more important things they can do to their health, and it can distract resources from other more important interventions. But even if we're going to continue to do it, we've got to be really sensitive to the overdiagnosis problem. So we don't always think that the best test is the one that finds the most cancer, because that's typically how tests are promoted now. This finds more cancer than that. Well, that's not a good test. I'm not looking to find more cancer. I want to find the few cancers that I can make a difference on. So it's really important that we get the system, even if we're going to continue to do cancer screening, we got to do it smarter and less ironically, we got to look less hard for cancer. We got to look for the few cancers that we really can make a difference on.
But how can we make that? How can we try to, I think, change the screening or improve the screening to look for those that really matter?
Well, I think the story is kind of best laid out in lung cancer screening. So let's just step back and say, in my country, and I suspect in yours, lung cancer is a trump card. And I'm not referring to my president now. It is by far and away the most important cause of cancer death. So it's a big problem.
But 90%, but 80 to 90% of them occurs in people who has a history of smoke, right?
That's right, about 80 to 90. That's the second point, is there's a really well-defined risk group. It doesn't take a genetic test. It doesn't take, it's nothing fancy. It's, do you smoke?
Mm-hmm.
So that really important cause of death, easy to find the high-risk group. That's a perfect situation for screening. And so it was the first cancer that really got studied for screening. And it was in the 80s, and it was chest X-ray screening. And the results were terribly disappointing. If anything, it looked like screening led to more death, not less. And that was partly because screening triggered operations, more operations. They're big operations and so forth. And so that was sort of the first lesson, like, wow, this is, it didn't help, and it actually led more people to have operations, and some of them died from the operation. That can't be good. And the idea that you could overdiagnose lung cancer was like crazy, but in fact, it looks like you can. Then the spiral CT comes along. And again, we say, let's look at this again. And I think that's perfectly reasonable. Let's see if now we can better sort things out. But they knew about the overdiagnosis problem. Those guys that put together that trial said, we got to be sure we get the right ones. And so one of the things I think they did that was groundbreaking is they said, if you have a small lesion on spiral CT that looks worrisome, but it's small, we don't act on it right then. We don't biopsy it right then. We wait 3 months and look at it again and see whether it's growing. Now that's real information. You're making use of the diagnostic value of time. And that's telling you something both about the genetics of the tumor, and it's telling you something about the body's reaction to it. I think that's a step forward. They're saying we're not going to start intervening until we actually demonstrate that this thing is growing.
That would be some sort of equivalency or analogous to watchful waiting, active surveillance.
Absolutely.
Yeah, it's actually one of the questions that people question me. It isn't better to start the screening test and monitor with time. But for example, if you're talking about prostate cancer screening, I think the active surveillance in that case is not easy as in the case of lung cancer.
Well, it's not easy as lung cancer? You think it's easier in lung cancer?
Yeah, you said that we do not biopsy right there. We wait and then do another image.
Right.
As far as I can say, I know that some people are talking about multiparametric resonance magnetic imaging for prostate cancer, but I'm not exactly sure how common, how spread it is.
Right.
And then I think the active surveillance or watchful waiting are done with PSA and biopsy.
Yes.
And then I think that's better than to operate right on. It's better, but I think there is risk of frequent biopsies, right?
Oh, absolutely. And there's risk. Absolutely. It doesn't. I think it's better. It still doesn't necessarily mean it's a slam dunk and that you have to do it or you want to play. I think you have to understand, if you want to go into a screening program and you want to avoid overdiagnosis, you also have to be prepared to say, well, this may be a slow process and I'm not sure what's, I'm going to be waiting for some period and maybe that's another harm of where you're saying, well, maybe I've got a problem, maybe I don't. And that's why someone like me says, I don't want to play this game. I don't want to live my life wondering about my prostate. I accept the fact I may die from prostate cancer. I accept that. It's not a very high risk. My overall lifetime risk is a 3% risk of death. I know I'm going to die from something. I'm not going to play the game. But someone else may look at the same thing and say they do want to play it. That's their call. All I think is people ought to know the deal. It's not a free lunch.
Yeah, that's one of my idea to disclose information. And publications are talking about shared decision making, but the harms are not hardly talked about, right?
Right. and it's hard. It's hard to know how you're going to react to this. You know how anxious it's going to make you, or so forth. But I can say that a slower approach is better in terms of sorting out who has the cancers that matter.
But two questions now. Is there any kind of information, let's say that one patient is doing screening, and then is there any information in that time of screening that could help that patient to decide between watchful waiting and or to treat right on? I don't know, Gleason score can help with something, or the PSA HAP levels. Is there anything that could help? I mentioned specifically prostate just to give examples, but we can generalize it if you prefer.
Yeah, I mean, I think we're getting better at characterizing tumors, and particularly in breast. You know, in the case of prostate, we have the PSA, and that helps discriminate what's aggressive and what's not. It's never going to be perfect. I don't think we're ever going to get to a perfect world where we can say this will never matter and this will always matter. I do think we can get better at it. Yeah. But that's another part of improving screening is to you know, try to identify those things that in fact are going to cause patients problems. And in some ways that we need to reflect our gold standards, not in terms of the pathology, but in terms of the clinical course of the disease. Too often our tests have been designed with the gold standard of pathology in mind, as opposed to the question of whether that cancer is going to really matter.
But how those strategies are being used right now? For example, as far as I understand, those clinical trials in prostate cancer screening, the rapid increased levels of PSA are not some sort of cutoff to postpone biopsy. Biopsies are done at a threshold of above 4 or above 3.0. But some individual doctors can say, no, we do not look to just PSA levels. We look to how fast they increase. My question is how those strategies improves or doesn't make any difference in screening for prostate cancer?
Well, I believe it helps. And I have to give credit to the urology community in the sense that they've gotten, they're sensitized to the problem of overdiagnosis, and they are slower to biopsy in general. And the evidence I can share with you on that is what our incidence rates looks like in our country. Let me, I see I've got low battery though. Let me just put you on hold for a second and get my power.
Okay, no problem.
I'm back.
Fine.
Just gotta feed the beast. Can I show you one more slide?
Oh, please do. As many as you wish.
Now that I'm learning how to do this. Okay.
I watched your presentation, I think, as your keynote speaker in a radiology conference. It was available on YouTube. You begin with talking about Mr. Baker.
Oh, yeah.
Yeah, I watched all that, and I found those graphs, incidence and mortality. I know the graphs, but the way that you present them, what tool did you use to create them?
Everything's PowerPoint.
PowerPoint, is just animation.
Just PowerPoint has a lot of capabilities that you might not think about, but yeah. So you're just looking. Everything I'm doing is PowerPoint. Okay, I'm just going to give you a quick riff here. Okay, you ready for 3 minutes?
Yeah, sure.
Okay, so this is the standard belief: prostate cancer screening bad, breast cancer screening good. Truth is, they're not that good. I'm just going to show you a couple of different cancers so you get a sense of what's going on. This is liver cancer in the United States. You're looking 1975, 2015. But this is the incidence rate, number of new cases, the rate of new cases in the population. How would you describe that graph?
Yeah, there's more cancers.
Yeah, there's more cancers, and it's real, and it's hepatitis C. Okay. This is leukemia, white blood cell cancer. How would you say what's happening here?
It's a little more stable, but
it's pretty stable, isn't it? I mean, maybe it's up a little, but it's really damn stable over 40 years. And this is a bladder cancer. How would you describe that?
It's stable, but looks like increased, but then it has been decreased recently.
But it's pretty all small, isn't it? Right? You know.
Yeah.
21. It's not much.
Not much. Yeah.
And stomach cancer
has been decreased, yeah.
So it's going down. It's been going down since 1950.
There's no screening for it.
No screening for it, yeah. Lung cancer.
Decreasing?
Yeah.
Less smoking people.
Up and then
less
down.
Smokers.
Right? It's up and then down. And it reflects the rise and fall of cigarette smoking with about a 30-year delay. Now, that's prostate cancer. That's the most common cancer, actually. And look how it bounces around.
Yeah.
Right? That's amazing. And, you know, as I say, you look, I'm just showing you the graph now in a more highlighted way. And I say, you know, there's no known tumor biology or carcinogenic process that can explain this graph. Right? And this isn't a small numbers problem. This is not a small numbers problem. This is the most common cancer in the database. It's just really bouncy. I mean, and then I say, oh, it tracks the BlackBerry share price. Do you know what a BlackBerry is?
Yeah, I know BlackBerry. So old company for
yeah.
It was the precursor of smartphone.
Yeah, but my point is, it looks like a financial chart. It doesn't look like a cancer incidence chart. And I don't know of a better example that of how the healthcare system affects the apparent amount of cancer. And I say there are really 4 parts of this graph. On the extreme, and I guess I go through, this is the growth of transurethral resection of the prostate. It was an operation that was done to help men who were having difficulty peeing because they had enlarged prostates.
Nice question.
And they shaved off bits of prostate, and more prostate went to pathologists, and the cancer rate went up. This is PSA promotion. This is when all of a sudden some hospitals start offering free PSAs, knowing full well they're going to make that money back in subsequent blood tests and biopsies and treatments. This is the retrenchment era where even the urologist said the one thing we shouldn't be doing is screening men with a limited life expectancy. Men with less than 10 years of life expectancy, they can't be helped by prostate cancer screening. And then this is, you know, active discouragement on the part of the U.S. Preventive Health Services Task Force, saying we argue against PSA screening. And what's remarkable to me is the incidence now is almost what it was
the same.
in 1975. So this, to me, makes a case, you know, the observed incidence of cancers is some function of how hard we look. And this is a scrutiny. This is a particularly scrutiny-dependent cancer.
Very great.
So I think that this is unbelievable what's happened to this curve, and I think it's good that our incidence rate is back to about what it was in 1975. I think that's a good thing.
But you mentioned that the USPSTF disencouragement being against PSA cancer screening. There's been some discussion. There's an article that say that after the disencouragement of the USPSTF, we have an increased advanced cases of prostate cancer.
Yes.
Yes, but how do you see those data?
Well,
do you think?
The first thing is that report of an increased number of late-stage cases was highly flawed.
Mm-hmm.
If you want to get into exactly what they were really just talking about counts. They never had a denominator. In the U.S. data so far, and I haven't checked the last year, metastatic prostate cancer first presentation has continued to stay stable. It may not. It may go back up. We'll see. Do you want to see that graph?
Yeah, please.
Published it in the... hang on, let me just get that. I published that in the New England Journal with a couple of... Hang on just a second. Manuscripts, metastatic prostate breast. Are you still seeing my screen?
Yeah, I see you.
Oh, you see me, but not my screen.
Now you're going to have to click to share screen again.
Yeah, sorry. Okay, so Skype, share screen. Then I got to get rid of you. Can you see it now?
No, not yet.
Oh, start sharing, yeah.
Yeah, now it's...
So this is the incidence of metastatic breast and prostate cancer.
Mm-hmm.
And just to be clear, these are people who first present at their first time they're found to have cancer, it is metastatic.
Mm-hmm.
And what you see is the implementation of PSA screening really had an effect on that. Almost, cut it in half. Mm-hmm. And it's been fairly stable, and I've checked about out to here, but I wouldn't be surprised if it comes up again because PSA screening is going down. But whether
Mm-hmm.
that changes the death rate is a separate question. Just because you lower lowering the incidence that people first present with metastatic disease is a sign that you're finding the bad cancers early.
Mm-hmm.
Whether that changes the death rate is a different question.
Yeah, sure.
Because that earlier treatment must matter. But I would fully expect, although we haven't seen it yet, it may take a while, to see this rate go back up. By the way, notice in comparison, the breast cancer metastatic, it's never changed. It's been rock stable.
Yeah, it's been rock stable. I'm going to make a question about the mortality now that you brought on, because all those cancer screening are measured using cancer-specific mortality.
Yeah, that's a great point. Yeah.
Yeah, and then we do not have evidence for all-cause mortality.
Yeah.
And how can you? What can you do about make sense of this data? Even cervical cancer screening, we don't have this kind of great evidence that reduces all-cause mortality.
Yeah, we don't, and I think that's a problem, and it begins to beg the question of what counts as a cancer death, and what do we want to have count. But in the context of evaluating a screening test, we're trying to see the full effect of screening. I would want a cancer death to include deaths due to interventions that involve looking for the cancer or treating the cancer. And I'm not sure we're getting that. And that's why all-cause mortality is important. If we're going to tell people that it's saving lives, we'd like them to know that it actually changes their risk of death. Because unless you want to play some game about, I care more about one type of death than another. But you're right. This is the underbelly of our database, the soft underbelly that we really don't know what it does to death in general. And it leads me. Are you still? I'm still sharing a screen. Can I just show you one more thing?
Yeah.
Just this drives me crazy. Let me just show you the colon cancer story. It's not what I wanted. Sorry.
Okay.
Yeah. So, can you see these graphs?
Yeah. Those screening, the fecal acute blood, or sigmoidoscopy,
No, this is fecal occult blood.
Okay.
This is the randomized trial that started us screening for colon cancer. It's the classic. It's the Minnesota colorectal cancer study.
Mm-hmm.
And it's now had 30 years of follow-up. And on the left, you see colorectal cancer mortality. And there are 3 arms to the trial. The control group's getting nothing. The biennial group's is every 2 years. And the annual group's getting every year. And as you can see, after 30 years, the annual group, 2% of them have died of colon cancer. In the control group, 3% have died. So that's the benefit. 1%, or the way we usually say it, is a 33% reduction. That's 1/3 reduction in the rate of colon cancer death. That's what got us to screen. But just about 3 years ago, they did this long-term follow-up, and they printed this graph, which they made no comment about. But I said, wow, this is in the New England Journal.
Of course, mortality is going up.
Everyone's 71% are dead in all 3 groups. And you might say that's a lot of death, but remember, back here they were age 50 to 80. So up here, a lot of them have died. But it's hard to say this is saving lives.
Yeah.
It may be trading off one form of death for another.
But the point of all-cause mortality that is interesting is that is what you said in the beginning. I might be avoiding a colorectal cancer death in one patient, but I might be
causing a heart attack in another.
Yeah, or even that same person, changing one death for another, or creating more deaths in the population.
And this is where you get these mixtures of effects. You might help someone, but you might hurt someone else. That's why it's not a slam dunk.
Yeah, let's bring you 2 questions for mammography screening. The first one is that you make the point that tumors that can be felt. And that I got a little bit misunderstanding because USPSTF does not recommend the clinical breast examination or teaching humans to breast examine the breast. So can you turn back your screen?
Yeah. Sorry. Just remind me what I'm doing here.
Yeah, it's
stop screen sharing.
That's right. That's great. And then you have mammography screening for humans that are completely asymptomatic. And then some humans can try to feel their breasts periodically. Maybe every day in the shower. I don't know. Maybe every day once in a while. And then, is that helpful? The human touch the breast, found a nodule.
So the data are clear that teaching women to self-exam it doesn't seem to help. Clinical breast exam doesn't seem to help. But that's very different than telling a woman that should she become aware of a new breast lump, we want to see her, right? It's not that it's just everyone should know. And by the way, thanks to mammography, I think most women do know if they notice a new breast lump, they ought to go have it evaluated. They'll get a mammogram. That's not a screening mammogram. That's a diagnostic mammogram. There's no argument about that.
But how to differentiate the two? I mean, in the message to the public, the new lump is something that you do not touch, but you felt.
Yeah, just if you become aware of a new lump, and you know, or your partner becomes aware of a new lump, you know, or when you're putting on your bra, you become aware of a new lump, or while you're washing yourself in the shower, you know, it's not like you need to go looking for them, but if you become aware of them, you know, get it checked out. I think that's that's a message that I think in general is already out there. I think women mostly know that, and there may be some groups that don't, but most, particularly educated women, would be aware of that. They might not have been aware of that 40 years ago. I mean, so part of the new attention to breast cancer has been good in that way. Ironically, it is entirely possible that a mammogram, a screening mammogram, could be the best way to do the clinical breast exam. You know, if we had a threshold of looking for things that were a centimeter or bigger. You know, ironically, I think a lot of the harms of mammography could be reduced if their thresholds for further investigation were much higher. It's just really hard. We've got about 500,000 primary care practitioners in this country. Getting them to do a systematic breast exam is really very difficult. It might be a lot easier to get 10,000 mammographers to do it systematic.
But this relates me to one of the questions I asked before. For instance, a human can be diagnosed with screening with the first type of breast cancer, the ductal carcinoma in situ, and then invasive. But even invasive has a rate of overdiagnosis. But let's say the human did screening and end up being diagnosed with more advanced cases. In that scenario, is there any doubt about treating or not treating, or is there any risk that human or the risk of overdiagnosis decreases as the stages increases in screening?
I think in general, overdiagnosis becomes less of a problem the higher your diagnostic threshold is. Right. You know, in other words, our typical pattern in medicine has been to always lower diagnostic thresholds.
Yeah.
Find more. That leads to more overdiagnosis. Higher diagnostic thresholds lead to less overdiagnosis. By the way, you're never going to take overdiagnosis to zero.
Mm-hmm.
Right? There's going to be that problem of someone that has a heart attack just after you found their cancer or something like that.
But the biopsy result can matter on that?
Yeah, I mean, a little bit. It's not as good as we'd like, but this is where things like Gleason scores and increasingly being able to genetically, evaluate the tumor, add some more information. None of it's perfect, but we can get better able to. But part of me, wants to move that back to say, how many people are we going to biopsy? Getting that next level of information, whether it's some genetic analysis of the tumor or whether it's going to be following things over time and making use of the diagnostic value of time, we don't want to involve too many people in that process. It's expensive, it's worrisome, it's all those things. And so we have to realize, the general conundrum with screening is we have to involve a whole bunch of people to potentially help a very few. And we have to pay attention to not disturbing the rest of them. That we have to find that balance. And I think until recently, it was all about the question of who we could help. And I'm just trying to say, we got to balance that with the people we know are harming.
But how do you think that we could change screening? For instance, Peter Gottschild have said that he gave his opinion that is it the time to stop mammography screening?
Mm-hmm.
He said that many times. And then other people think Laura Esserman would oppose to move to risk-based screening.
Right. And by the way, I'm a total, everything changes as you move to a higher risk population, right? It makes that they're less likely to be overdiagnosed and they're more likely to be helped. So that definitely, so moving to a higher risk population helps. Although with breast cancer, once you get done with BRCA1 and BRCA2, they're no real powerful risk factors.
But I have said briefly this week and last week that even BRCA has some sort of variants that we don't know the clinical significance.
Yes, you're absolutely right. We're now, that was an overly simplistic statement. I was talking about 1 and 2, and now we got all these variants that I don't even know what they mean.
And
so we're getting a lot of noise here.
A lot of noise, yeah.
Yeah.
And there's been some people that have said that we use the number need to screen, the number need to invite to screen, as opposed to number need to screen. Is there any difference on those?
Sure there's a difference, because there's some people that you invite that don't come. So the number needed to invite to screen is always going to be higher than the number needed to screen.
But but even the USPSTF in those infographic decision aids, they talk about, I think, the number need to invite to screen. So to reduce one prostate cancer death, for example, it would be 10,000 people to reduce. And some people have said that, like we are, I don't know, giving the wrong data because the number need to screen are actually very much less.
I think it's all first. This is kind of the kind of discussion that makes my eyes glaze over. It's not that important, but I guess for the individual who's considering screening, they'd rather have the number needed to screen. For the policymaker considering whether to put in a screening program, they'll think about the number needed to invite. So it's all about your perspective. But to me, that number, both of them are misleading in the sense that that's not what I want to know. What's going to happen? What's the variety of things that are going to happen? We're always focused on what that benefit is. I want to know, well, what else is going to happen? First this whole question of, am I really going to live longer? And then the more basic question, am I going to live better or am I going to live worse?
And then just to wrap up, how the screening data regards mortality? You talked about briefly in one of those slides. We talk about lung cancer, but if you go for example, is there evidence that cervical cancer screening, for example, reduces mortality for cancer of the cervix?
Well, we've never had a randomized trial of cervical cancer screening. It became hardwired long before we even considered randomized trials. There's a lot of observational data that suggests it's helpful. My guess is it's helpful. All other guess is it doesn't explain the 80% reduction in cervical cancer that we've seen that in stomach cancer too, and we did nothing. I think there's also environmental HPV infection rates are falling. This cancer is disappearing. That's colon cancer is also on the downswing and started long before we started screening. So other things change cancers. But my guess is that cervical cancer screening has had some effect on cervical cancer mortality, just as colon cancer screening has had some effect on colon cancer mortality. I think breast cancer screening has had a little effect on breast cancer mortality. I think the big effect has been treatment. Our treatment has gotten a lot better. That's good news. I think the same thing's true in prostate cancer. I think prostate cancer screening has something to do with our fall in mortality, but I think treatment also does as well. As we learned that both breast and prostate cancer are hormonally responsive diseases.
But can you say that the reduce in prostate cancer mortality has been less clear than in breast cancer mortality for screening? The trial, I know those trials for mammography are old ones, and the effect could be bigger, but the PLCO did not show, there's contamination, but did not show mortality reduction.
Yeah, I think you've got more trials in breast cancer than you do in prostate cancer. The prostate cancer trials are newer. PLCO is totally contaminated. You're right, very small effect. The European trial looks like it's about a 20% reduction. By the way, both those trials were individually randomized, while most of the mammography trials were not at the level of the individual. They were geographically randomized. To me, it's a guesswork as to which contributes more to mortality. But I do think, in general, in both cancers, our treatments have definitely gotten better, particularly in breast cancer. They've really gotten a lot better.
And to finish up, how do you think is the best way to communicate those complex data to the public? I've heard a comment that I think we both do not like the comment, that those kind of complexities should for now stay in the medical community, that the public, the lay public, the general audience, right. And I cannot disagree with that more. I think we know that for quite some time now, the issue of overdiagnosis and overtreatment.
Yeah. I think when we're inviting people in to the medical care system, we got to tell them the truth. We got to tell them as balanced as we can what the deal is. It's very different than a patient's coming to me asking for help, with a specific problem. Here is a place where I or the system is inviting them in, and they ought to know the deal. And that means they should know the downsides as well as the upsides. And by the way, it's easy to forget, but there's money here, and this money isn't just about people making money, it's about making other people poorer. And, putting people under financial stress, and that can happen from screening. All of a sudden you get some really big bills if we have to start doing more pathology, doing genetic tests, and so. And putting people under that financial stress, I can tell you, that's not good for their health. And they ought to know that this may take time, it may be expensive, it may be worrisome, and worse, we may do something that really hurts you. And yeah, we might help you, but this is kind of a close call, and different people can look at the data and come to different conclusions. This is not the most important thing a healthcare system does. We act like it's the most important thing we do. It is not. The most important thing we do is we help with sick and suffering patients. We witness their suffering. We help them through death. We help them through family issues. That's really important. All this other stuff, we're inserting ourselves into the regular lives of people, and it can work two directions.
Is there any other comment you'd like to make?
Oh, I think I've lectured enough for one. I made good slides and everything.
Yeah, well, it's excellent. I couldn't expect this great time and experience we have together.
I want to talk to you. Can you show me out the window in Rio? Can I see Sugarloaf?
What? I'm sorry? Sugarloaf. If I was back in my office, I could show something, but
where are you?
I'm in. I don't know. Do you have come to Rio?
Yeah, I had many years ago.
I'm in Tijuca. I'm in my apartment. You cannot see anything from trees. Okay. And you in the back office. So this is my room.
Okay, well, that's good. Honestly, when I first looked at it, I thought it looks like a surgical locker room.
No.
Because it has lockers on the back there.
No, it's just closets.
Okay,
in there.
I'm going to show you one thing before I go.
Okay.
You recognize that?
Yeah, this is a Macintosh, a very old one, right?
That's my first computer. It still works.
It still works. Amazing.
Still works. Yeah, I bought that. I wrote my first paper on that.
Very interesting. I'm by formation I study medical. I'm sorry, I'm studying technological. I'm computer scientist by formation.
Oh,
Degree, bachelor degree, and my master degree was informatics actually.
wow.
And then I changed, not in professional. I still program as my professional.
Yeah. Wow. Well, I realized I bought this in '88, and it's 2018, so that's 30 years old, I guess.
But when do you turn on?
You want to see it?
Ah, okay, do. But do you use it for something or?
Well, I actually brought it out the other day because it had been in my closet, and I just said I'm going to put this on my desk.
Mm-hmm.
I hadn't turned it on for maybe 15 years, and I had to turn it on a couple times before it fired up. We'll see whether no. See, welcome to Macintosh. Isn't that great?
Fascinating. how technology has changed those times.
Yeah. I think I even designed that desktop. You probably can't see it, but it had a little option that you decided how you wanted things to work. Oh, and this is a piece of software you can't find anymore. Claris Works. I used to do drawings with, for my first graphs were done with that kind of stuff. That was before PowerPoint.
That was before PowerPoint, yeah.
Well, I'm sorry to do that to you, but I just thought I had to show it to you.
No, very interesting. Let me try to make a proposition, see if you're interested. I'm not sure if it's going to work, but I think we are in March now, and those screening campaigns come, at least as I know, in a couple of, 5 months from now, 6 months from now, in October, November.
Yes, that would be prostate and breast implant.
Yeah. So I tried to do something back last year and didn't work. So my screening article was published in January and February. Right. So I would have your interview article, and so if you could write something small for the public together, and I could actually try to write another, so make some sort of special section screening, or even a special issue. You do not have to answer me now. Think about it.
What are you asking me to do? To contribute an article myself?
Yeah, that would be fascinating. I don't know. I just wrote one on my own, discussing problematic screening, 5-year mortality rate, those kind of things that I think could help. And right. Together with the interview, facing together in the same issue, maybe the editor of Skeptic Magazine or Skeptic Inquirer Magazine will do some sort of.
Are you saying working together on an article or two different articles?
Well, I'm open to both possibilities. What you think works the best?
Here's what I'd say, and I'd think about it more. But I guess I'd want to know that the editors were interested before I devoted a lot of effort to it.
Okay, I will try to make.
So if you start something and you say, if it would help for Dr. Welch to write something in the box or something, he would, or or you could approach me, or something like that, and we talk more later.
Okay.
See where I am.
Okay. Thank you.
All right.
Very much appreciated those slides and so forth.
Sure. Yeah.
Thank you very much.
And you saw the thing. I think when I was speaking to pathologists in Vancouver.
Yeah, I guess it was.
Purple, a lot of purple.
Yeah, a lot of purple. Yeah. Would you mind to send those lectures, the PowerPoint presentation to me, or you do not share? You often do not share.
I often. What did you want me to send you?
The presentation. I would like just the animation of the mortality, the incidence going up, and the mortality stable.
Okay. Yeah.
For breast cancer, I guess that you show them.
Well, breast cancer mortality is going down.
Going down, but I think you show the incidence going up, and the late cases. There's two slides that are interesting. What would be expected from optimal screening? The increase in the early stage and a decrease in late stage disease.
And what will you do with them?
I would present to my friends, just my friends.
All right.
not very thing, not public things, but every time I do, your name would be below as a source.
Yeah. Okay. Yeah, no, I'll send them to you right now.
Thank you.
All right.
And much appreciated for your time.
All right. Yeah. Good talking to you.
Thank you.
Bye.
Best wishes. Bye.